want to get to our first topic, which is about patient selection. So one of the things that no matter what your practice is, whether it's primarily degenerative, primarily deformity, tumor, adult, pediatrics, trauma heavy, whatever it may be, ultimately choosing the right patient and choosing the right procedure for that patient is essential. So ultimately, a problem that we all face is who needs what operation, who needs what technique, and matching that procedure to that patient. So something that we've talked a lot about in the past, and we're going to discuss a lot today as well, is choosing the right patient and how you best evaluate that patient. Because I think that is something that choosing the right patient is kind of like choosing the right outcome for that patient as well. So we'll get into it. So first, I want to bring up a case just to kind of get everybody thinking about a classic case of deformity that needs to be addressed in a complex way. So here's a case. So we're going to go to a panel in a minute, but I want to get everybody thinking about a case that we all see all the time. So this is an older gentleman who's got a previous fusion, L2 to S1. He's got a lot of back pain now. He's leaning forward more. He's got a lot of leg pain when he stands up. So all these things, these clinical clues that we start with, start to kind of guide our thought process of what does this patient need, what's he had done in the past, and we start evaluating the things first with X-ray, with MRI, and you can see here, standing EOS films show his overall malalignment, the previous fusion he's had, etc. Then we get in a little bit more detail. We look at an MRI, right? So probably similar in all your practices out there. Patient comes to your office with X-rays or an MRI or a CAT scan, whatever it may be, all these things together start putting together that picture. So we start evaluating these things. So in your mind, you're starting to think about, okay, what does this patient ultimately need? So you can see here, he's relatively forward, he's got a previous fusion, he's got stenosis above his fusion. If you look at that thoracic MRI, he's got stenosis again up around the level of T10, T11. How does all this play in? You start to evaluate it a little bit, you get a CAT scan. And you see a few things on this CAT scan. You see, okay, he's got pseudoarthrosis at L5-S1. You can see the vacuum disc there. You can see lucency of that right S1 screw. You can see a lot of degeneration, vacuum disc above the fusion, etc. So you're starting to put this whole picture together. Then you start making some of your measurements, right? And we'll talk a lot about this in a little bit, and we'll turn to our panel in just a minute with all these things, right? So you're starting to frame in your own mind, what should I do with this patient? What does this patient ultimately need? And probably the most important decision we can make in taking care of this patient is coming up with a plan on how to take care of them, right? So you can see the measurements here. So grossly, sagittally malaligned, he's got a PI-LL mismatch. Ultimately, we're starting to think about what does this patient ultimately need. So what I want you guys to do now is to, through the polling function on the platform, is vote for what you think you would do with this patient. And maybe all the information is not there just yet, but in starting to put the picture together, I want the audience to start to decide, what do you think maybe you do? So you can see your 5 choices there. So let's start thinking about those things, and then we're going to go to our panel. We'll come back to this case in the end if we have time, and see what the audience chose then, and compare it to what they choose after the talks, right? So the panel that we have today, certainly world-class in all aspects, talking about aspects of patient evaluation from a medical standpoint, a radiographic standpoint, from a surgical standpoint, and trying to put it all together. All right, so now I want to pass things on to Dr. Frank Shen, and he'll go through the radiographic evaluation of a patient like this, and ultimately how you best decide radiographically what a patient's going to need. Frank?
Thanks, Pat. This is a large topic that in some shape or form, as you said, we all will be having in our practice. I'm going to just go over the radiographic and some of the clinical things that I think about. So when we talk about adult spinal deformity, this is exactly what we sort of think of as our classic image. But if you think apple, if I say apple, this is what you think of. But if you talk to an apple farmer, this is really what they see in their mind. So if you look at this case here, this is an adult spinal deformity case. This is an adult spinal deformity case as well. This one's an adult spinal deformity. And this is adult spinal deformity. So they're all adult spinal deformity. And what we need to do is try to decide what each patient needs. So if I put together some of the radiographic considerations and the clinical considerations, we try to design a surgical plan. So this is kind of a 30,000 foot look down. And the things that I consider right off the bat are the alignment. And so if I talk about alignment, I'm really thinking about the coronal and sagittal plane alignment. I want to think about the magnitude of the curves, both in the coronal and sagittal plane, because one might be larger than the other, or they may only be one plane deformity, and where the apex of the curve is. And that's important as well, because the sagittal apex of the curve might be at the thoracolumbar junction, but the coronal plane apex might be lower or higher. So they may not be at the same point, and that might make you decide where you're going to address your osteotomies. And certainly flexibility and stiffness of the curve is important as well. And I use the supine CT and MR as a surrogate, as you sort of mentioned through in your first case example. Certainly, I look at stenosis, where the levels that are tightest, right and left versus central and lateral recess. But you have to correlate that because the imaging is often overreading the amount of stenosis. And then the last thing I'm always looking for, especially in revisions, is pseudoarthroses, right? And what we're looking for is areas where there might be opportunity for us to gain advantage, to attack that curve and to try to restore the alignment. So I think pseudoarthrosis is a big part of what I'm always looking for. If you look at this case to the left, to the right, you can see where before they had lateral plate, and the use of a lateral plate takes away a lot of your areas where you can attack a curve. So going above it is often what I'll do in those cases, or think about removing the plate. Let me just go through some of the radiographic parameters. There are many, but for the sort of the meat of what we think about is the pelvic incidence and the lumbar lordosis. And we know there needs to be a match between them within about 10 degrees. And that helps set up the base of your spine. We also know that the sagittal vertical axis, the SVA, should be within about 5 centimeters of the posterior aspect of the superior of S1. And the pelvic tilt, which really gives you a sense of what the pelvis is doing, whether it's retroversion or not. You want that to be under 20 degrees or about 50% or less of your pelvic incidence. I think this slide, everybody's seen in different shapes or forms, but on the far left, that's a patient who has a small pelvic incidence. And if you have a small pelvic incidence, a small PI, your sacrum is going to be relatively vertical, so you need a small lumbar lordosis to match. Whereas on the far right, if you have a large PI, you're going to have a relatively horizontal sacrum, so you're going to need a large lumbar lordosis. And so that's where the match of the PI and the lumbar lordosis comes through. If you have a mismatch of that, you'll end up with an increased malalignment and increased SVA. This is a little bit about the pelvic tilt. On the left, you see a normal pelvic version, and the pelvic incidence is a set parameter. So on the right, you can see that as a patient has more retroversion, that pelvic tilt, that angle starts to increase. So that is a parameter that's going to give you a sense of what your pelvis is doing to try to accommodate. So you can rock your pelvis back as you have a positive SVA, and what you'll see is an increased pelvic tilt. I think those three numbers help set the radiographic parameters, but it's really important to understand what the patient's clinical goals are, right? So what's their main complaint? Are they having more back pain or leg pain? Is it neurogenic claudication, or is it radicular? And you need to really understand their expectations, right? What are they trying to get back to? And in this aspect, I think about their vocation and their avocation. When I was a resident, my hand surgeon mentor would tell me that if you fuse the wrist of somebody who works on drywall, they'll be unhappy, because on the picture on the right, you'll see that in order to plate sheetrock, you really need to extend your wrist. Well, if you have a patient who's a very avid golfer, if you do a thoracolumbar fusion on them, the loss of rotation will make them unhappy if they're not aware of that. So I think it's really important to understand what their goals are and what they want to get back to. When we think about deformity and stenosis, we think about them in separate manners, but it really is a continuum, right? There, on one end, you have deformity, pure deformity, or you can have deformity with stenosis. On the other end, you can have stenosis, and you can have stenosis with deformity. And so down here at the very bottom is the importance of the clinical exam and the history. So you can have deformity with stenosis and stenosis with deformity, and they're very subtle but different. You can have the same radiograph and be looking at it and have two different thought processes because of what their clinical complaints are. So if we look at this patient at a 30,000 foot overlook down, this is a patient that has relatively good sagittal coronal plane alignment, but they have a mismatch in their sagittal plane. It's a solid fusion. You can see that they've had multiple surgeries with some screws being removed. This is their coronal alignment, which is pretty good. You can see that their parameters show that they have a large PI and a small lumbar lordosis, so there's quite a bit of mismatch, and their pelvic tilt is relatively large, so they're retroverting their pelvis. Despite that, they still have a large SVA of about 14 centimeters, so they're sagittally malaligned. So this is a revision, solid union, sagittally malaligned. I'm really going to attack this sort of where the apex of that sagittal curve is, maybe the thoracolumbar-lumbar junction. My osteotomies, and I'm going to pick my proximally up to where the previous hook was, so T3 down to the pelvis, and do my osteotomies at the sagittal, attacking the sagittal alignment. This is that case of a patient who has relatively, if you look at the numbers, level alignment in the sagittal plane, but coronally off. It's an unusual looking curve, and as you would imagine, they're being followed by neurology for some neuromuscular disorder. I always look at the shoulders. You can see that the left shoulder's up and the right hemipelvis is up. So if you level this patient in the coronal plane, you always have to think about an upper thoracic curve, which this patient doesn't have. So as I pick my proximal and distal levels, perhaps the T3, T4 down to the pelvis, I'm really going to attack the coronal plane. So that apex is at around L1, L2. The parameters in the sagittal plane seem pretty good, but you can see the kyphosis is a little bit at T12, L1. And this again will be T4 to the pelvis with my osteotomy centered in my coronal plane. Level the shoulders and set it based on the pelvis. This one is a classic pseudoarthrosis. You can see the broken rods, and CT confirms a non-union at that level. So this is really an area where I'm going to attack. I'd like to get most of my lordosis at L4-5 and L5-S1, but with a plate anteriorly at L5-S1, it really leaves me L4-5 and perhaps within the prior fusion proximally. So proximal anchors, you can see the increased PJK, proximal junctional kyphosis. So I'm going to go up to T4 to try to gain the hyperkyphosis. It's relatively flexible on the lateral radiograph, and I think really attacking L4-5 and 5-1 and going to the pelvis is what I would do here and getting a solid union. And you can see sort of gaining your, restoring some more normal alignment at the L4 to S1. This is a 73-year-old who comes in with a little bit of coronal shift to the left, and their sagittal alignment looks pretty good, but they're complaining mostly of leg pain, right? So this is a leg much more than back. They've had this deformity for a while. Their left shoulder is a little elevated, but they're comfortable with that. They're really complaining of their left leg. So in this case, for me, this is really a stenosis with some deformity. We think about those parameters there, but if I look at the pelvis, pretty level, but the lumbosacral takeoff is off to the left, and there's stenosis on the MRI confirms that at L4-5, 5-1, there's stenosis on the left in particular. And so for this patient, they got a short segment, decompression, and really try to address that takeoff to open up that level. And this is their standing radiograph, and you can see that the curve and the coronal sagittal plane have remained. I'm really attacking the stenosis in this case. So I think in summary, you need to be aware of the radiographic values. They're very important to help you design sort of where you're going to address your curves. Be aware of the overall radiographic appearance, but understand what your abilities are and how they fit into that patient, and also understand what the patient's goals and expectations are. Thank you.
I have a question for Frank. When looking through your case there, Dr. Shen, the classic flat back is always hard to evaluate in terms of how much correction you're going to need and where you can get that correction. How do you decide in looking at that where you're going to get the correction that you need and how much do you have to do? Is it a 3-column osteotomy? Can you do posterior column alone? Where can you get that correction through an inner body, et cetera?
Yeah, Pat, that's a great question. And it's one I think all of us struggle with every day. And it goes back to understanding what you can achieve in your hands. And I think a lot of these new planning softwares will help you understand better. But to your point is if it's a primary, you really want to get a sense of how stiff that curve is and whether you use push pull or traction or prone or supine laterals, it'll give you a better sense. And if it's a stiff curve, rigid curve, I usually want to attack the apex of that curve. So if it's a short segment stiff curve, I'm going after the apex. If it's a long sweeping curve over multiple segments and is somewhat loose, I'll do just posterior column osteotomies. I think you hit it on the button when you talk about a revision, and I mentioned it too. I'm really looking for areas to attack that deformity. I really like to center at L4-5 and L5-S1. That's where most of the lordosis is going to be at, but oftentimes that's taken away from me by lateral plates or anterior plates, and so you can still go in and remove the plate, um, but um, but oftentimes I'll have to go a little higher. It will restore the lordosis, but the lordosis might look a little bit funny, and it may not level the L1, L2 if you do your large curve corrections at L1, 2, 2, 3. So I'm cognizant that the overall alignment might look good, but at focally, the transition of that osteotomy up higher does set up some problems down the road.
Great, thank you. All right, John, let's go back to Louisville and see if we can get those slides going.
All right, there's my disclosures. It's John Dimer from Louisville, Kentucky. I'm going to talk to you about medical optimization. We started with complications, then we went in the early decade ago to patient safety, and now to risk stratification. And we're really now going to AI to try to improve our patient outcomes and catch complications that may be preventable peripherally using very careful clearance techniques. I advise you all to look at Raj Sethi's articles where he really did a team approach to this with a multidisciplinary panel. And what he really found was that you can really reduce a lot of the complications. The two surgeons are better, and blood loss is better, and your complications go way down when you have a team approach. Really, when you do medical optimization and clearance for these patients, there's three pathways really. You can go with the traditional multidisciplinary, but if you don't have those capabilities, you also can assemble a good team. And you also might want to consider what we do as a nurse navigator to look through all these things that you don't have time to flag anything that might be a bad lab value and everything. So it's a really good way to look at it. We're going to take a look at three things: obesity, diabetes, and osteoporosis, which I think are some of the biggest non-cardiac things that we need to look at as far as the actual problems that we have to deal with on a day-to-day basis and everything. Diabetic control is essential. All of these problems are associated with it that you saw there. And about 5 to 20% of your patients actually will present with diabetes. And there's a lot of large multi-center studies that tell you how to treat these, particularly with other surgical procedures. So it's something we really need to pay attention to. Basically, there's a little slow here. There's really kind of do a couple different things. Normal, the insulin drives glucose into the cell. Type 1 diabetes, you don't see those patients often, but most of the patients are elderly type 2s where they're just insulin resistant. It doesn't really affect the end tissue and everything. So when you look at a couple of articles here, let's see if I can get this to advance. Here we go. When you look at, Brown looked at a large cohort of these patients of 11,000, and what he really found was that diabetics frequently require more transfusions, have a higher infection rate, and have higher hospital charges as we would expect. Takahashi looked at this and he found that an A1C over 6.5, which is really the metric you ought to use to clear these patients, was associated with a significant potential postoperative complications and just basically poorer outcomes after the surgery. But the article I really want you to pay particular attention to is by Hikata, and it basically kind of set the standard for the fact that you want to have an A1C that is at least 7 or below. And this will really dramatically decrease the postoperative SSIs that you get. So that's something that should be addressed preoperatively in every case if you can, short of an emergency. Well, it takes a while for these to go through. So the take-home points for diabetes, if we can go back there. Take-home points are: get the A1C down below 7. Remember that these patients have a high complication rate. And remember that if the sustained glucose is over 200 after surgery, the infection rate can jump up to 8 times what you would normally have. So make sure you have a post-operative regime that you basically can put these patients on to treat high glucoses. We'll talk about obesity next. This is a big problem in the United States. Basically, we like all our pizza and everything else. And so as a consequence of this, in this country, we have about a third of our patients overweight. People are overweight, and a third are just frankly obese in the United States. So this is a real problem with our surgical intervention. When we look at obesity, we find that basically Singh looked at this and he found that it's associated with all the things you would expect: high blood pressure, pulmonary disease, diabetes. Oh, you want me to stop? I'm sorry, you're cutting it. Anyway, we'll continue. There's a little over talk. Anyway, we really want to look and see and know that these patients have all these associated abnormalities. Raphael Burba looked at this and looked at a large cohort of patients. And what he found is really simply this: is when you start talking about patients with BMIs over 40, you can see on the right of the screen there that they have all sorts of complications, infections, heart attacks, DVTs and everything. So these are the patients you really want to try to avoid as far as increased complications that you're going to have to try to do something more for. They additionally found that you can also be underweight. Cachexic people also have a much higher incidence of infection and complications. Common sense, we've known this for decades, is just now really quantified for us. When we look at, we're not getting the slides to advance here again. Here we go. There it's coming in slowly. Hope everybody can see this. When you look at, Babu looked at basically what happens when you have both diabetes and obesity, and he found that there was really almost an additive effect as expected to have significant problems with infections and other postoperative complications. But what he really looked at was the fact that even though you may be obese, if your back is thin and you don't have a lot of fat on the back, this is particularly true in men, you may actually in fact have a much lower infection rate. So a really great paper that won the Young Investigators Award that I've always liked is John Lee's paper, and he really quantitated the amount of body fat that you can have. And the bottom line is for every millimeter, you get a 6% increase in your infection rate. In other words, 50 millimeters would be a 4 times greater risk of infection. And this was a very important finding. And so you want to pay attention and look at the patient's back, because a lot of times they may have a lot of centripetal fat on their abdomen, but in fact, they may have a very thin back, and that will be beneficial from the standpoint. So the sub-Q thickness on the back is a superior indicator to their BMI as far as developing a postoperative infection. Just another really good thing to look at. Hope we can get this to go. So again, diabetes and obesity, when they're combined, it's all independently increased postoperative infections. It's an additive effect. So the summary slide for this, if it'll come up. Basically, you want to get the patient's weight down before surgery. You want to consider the fat thickness, and you want to consider weight reduction and stay away from the patients that have BMIs over 40 for elective surgery. So we're going to talk about osteoporosis next. A big topic. I hope it's very slow slide advancing here, so it's going to delay things. Osteoporosis, of course, is basically a decrease in bone quantity, and it's frequently associated with osteomalacia. Why it's important is not only can it cause vertebral fractures, but it also can cause screw loosening and proximal junctional kyphosis and poor healing. And there's plenty of good, decent literature, level 3 literature to show this as a real phenomenon. All these patients you operate on, they should all have DEXA scans done. You can also substitute, in my opinion, a CAT scan, because basically a minus 2.5 equals a 97 Hounsfield unit as a general rule of thumb. So most of us will have these available, so we can just simply use the CAT scan in lieu of this. There's absolute evidence that shows that preoperative vitamin D deficiency is very common. So you should always check these patients preoperatively because it does help with effusion. Also, when you look at the incidence of osteoporosis in your operative patients, it's 45 to 60% of the people will have poor bone health, which is a lot. That should be treated preoperatively if you have an opportunity. Here's a paper by Kim, then when he looked at basically vitamin D status, if the vitamin D levels were substandard or below 20, basically the patients also seem to have poor outcomes. Another case by another paper by Ravanda found that basically that patients with low D3 levels had a relatively low fusion rate compared to those that had normal levels with a probability of 4.96. And he came back with 133 fusions that he looked at, and he looked at the time to fusion, and he found that patients that had less than 20 milligrams of vitamin D3 had a 12-month fusion rate versus 6 months that had normal levels. Again, some important evidence of why you need to treat this. Another paper by Bergerke found that basically when you have poor bone quality osteoporosis, you can see that you have 50% complications, and your new rate also skyrockets. Again, a reason to treat osteoporosis. It's very, very important in our fusion patients. We want to basically build bone production, and you need to make sure that the calcium's okay, and use the table on the right to prescribe it on patients you might suspect are low. You also have all these marvelous drugs that have come effective in treating osteoporosis, particularly the teriparatide and the bisphosphonates that you want to consider when you're using yourself or sending to a bone specialist. So they really work in two different ways. You have catabolic, okay, which works here. And then you have anabolic. Anabolic build bone, catabolic don't build bone. Here we come. Slow internet connection today, everybody. So basically what you want to do is you want to build either bone using the teriparatide, which are parathyroid analogs, as you see here, or you want to actually slow bone reabsorption using the bisphosphonates and nimosumab, as you see on the left of the screen there. So there are authors that have looked at this. All these authors on the left here show there's a positive effect of bisphosphonates in bone healing postoperatively. Next authors looked at teriparatides. Here they come. Teriparatides also have been shown to improve bone fusion particularly by Altura and Ibata, as you can see here. Positive effect on bone healing. And particularly
Thank you, John, for going through all that. We're having a couple of different issues from a technology standpoint, but I guess one more question. Frank, for you, we talked about this a little bit earlier. What is your go-to when it comes to, I'm trying to avoid a 3-column osteotomy in a given patient. What is your go-to to try and get the correction that you need?
Yeah, that's a great question. I'm moving away from 3-column osteotomies, as most people are, but occasionally need to. My go-to is intradiscal osteotomy. So it really is a PCO with an anterior column. So it really is an inner body. So intradiscal osteotomies at multiple levels, very powerful actually. And whether you want to do that through a single approach, anterior, posterior, or anterior then posterior, single position, I tend to do it all from the back. It allows me to control the dura on the roots too. So I like an intradiscal osteotomies.
Excellent, excellent. Well, thank you to our panelists. That was great, discussing different issues that we all deal with on a day-to-day basis in terms of trying to evaluate which patients need which operations. So, again, I want to encourage the audience to continue this discussion. I'm sure we could talk about this all day. So please ask questions through the chat, discuss with your colleagues, reach out to the faculty. Please don't hesitate to do that.